Okay, shock. So I think, layman's terms of shock, I don't know that it truly reflects the accurate pathophysiology of what actually occurs in shock. You hear people, laymen, say, oh, he was in a car accident and he went into shock. Or, oh, she's in shock, or, something like that. What does that even mean? And it probably is not even accurate with what pathophysiologically is actually occurring in shock. So let's talk a little bit about what it actually is. And it'll be quite different than how people use it. So here are your objectives for the shock aspect of Chapter 23. Okay, so in my sort of oversimplistic, corny sort of explanation of what shock is, the way I always think of it is shock is truly a tissue issue. And what I mean by that is it is a very sort of complex clinical syndrome that's characterized or sort of caused by a decreased blood flow to the tissues of the body, which obviously, I hope, after this entire semester that we have spent together, should sort of very intuitively mean to you that obviously if there's a lack of blood flow, there's a lack of oxygen getting to the tissues, that you're going to start to see cellular dysfunction and or death of the tissues, and then ultimately the organs that those tissues make up, right? So that is what shock is. It is a tissue issue. There is a lack of blood flow getting to the bodily tissues, i.e. the bodily organs. So that is what shock is. You see this a lot in critical care especially, in the real world. Because, and the reason for that is, there are lots of different reasons for why there could be a lack of blood flow getting to the tissues, okay? But generally speaking, the reason, for whatever reason may be the cause for a lack of blood flow to the tissues, the cardiovascular system, for some reason or another, is failing to perfuse the systemic tissues adequately. So obviously, as we just said, this does lead to all those impaired cellular metabolic activities that we talked about at the beginning of the semester, right? So we'll start to see the tissues have to switch into anaerobic glycolysis rather than the aerobic sort of Krebs cycle, citric acid cycle. We know that with glycolysis versus the full true Krebs cycle, that we produce way less ATP. We've talked about that ad nauseum already this semester. So with lack of oxygen, therefore lack of energy, you see the cells start to dysfunction, right? You see those cellular pumps fail, that potassium-sodium pump that we talked at the beginning of the semester about, you see that fail. When the sodium-potassium pump fails, you start to see sodium accumulate in the cells, right, because it's not able to get pumped back out. So, and what happens with water, with sodium? What does water do in association with sodium? It follows it. So if you have sodium coming into the cell, coming into the cell, coming into the cell, water is going to come into the cell, come into the cell, come into the cell, and it actually causes major, profound cellular swelling as water continues to enter, and not able to get pumped back out. So what eventually happens is the cells get so big and enlarged because of this increased water content of the cells, they rupture and die. So that's one way that the tissue gets impacted by this lack of energy. You'd actually rupture and die because of the lack of energy to pump that water and that sodium out. You'll also see lactic acid accumulation. Again, lactic acid builds up whenever you've got a lack of oxygen to the tissues. So you'll see a pretty profound increase in what we would look at clinically as a lactate level. You can actually draw a lactate level on someone who you think may be in shock or have some sort of shock-related pathophysiology, and they'll actually have an increased lactate level in their blood. That's why, because of the lack of oxygen in those tissues. So given that sort of pathophysiology of what it is, manifestations certainly vary based on the stage, so how profound their shock is. And there are sort of stages, if you will, of shock. We're not going to necessarily talk about the specific stages today. What I really want you to understand is just the sort of general pathophysiology of what shock is, that it is that lack of oxygen to the tissues. But again, depending on which stage you're in, you're going to see some manifestations because of hypotension. When someone is hypotensive, what does their heart rate usually do? increase to try to compensate for that hypotension. So oftentimes you'll see hypotension and tachycardia go hand in hand in these patients. And you also may see an increased respiratory rate in these patients that are sort of going into shock. Why might you see an increased respiratory rate in these patients? They're trying to increase the oxygen content, whatever is there, to try to increase that oxygen content getting to those tissues. So they're going to breathe harder, faster, more rapid to try to compensate for that lack of oxygen in the tissues as well. Good. Very good. Okay. So does this slide make sense to you pathophysiologically speaking? Okay. Because, as I show here on the screen, it really truly is, shock is really truly just impaired cellular metabolism, right? And the reasons for this lack of blood flow to the tissue or this impaired cellular metabolism are many. There's a lot of reasons and a lot of different reasons for why this might occur. They can kind of be categorized into two sort of umbrellas. One, it could be relative hypovolemia, could cause this lack of blood flow getting to the tissues, or absolute hypovolemia. So really quickly, give me an example. We kind of talked about this already throughout the semester. Give me an example of something clinically that might cause relative hypovolemia. And by relative hypovolemia, I mean they haven't necessarily lost their volume. It's not out on the sidewalk because of a massive gunshot wound. So where is their fluid? What would cause relative hypovolemia? Burn. Good. Well, actually, well, it depends on which aspect of the burn you're talking about. If you're talking about the sort of increased capillary permeability of a burn and that how the fluid goes out into the interstitial space, yes, I would agree with that. If you're talking about the actual loss of fluid through the burn on the skin, sort of that evaporative loss, that would be more of your sort of absolute hypovolemia. So I would actually put burn in both categories, which is, again, drives home that point of how dangerous burns are. So good. What's another reason? Yeah. Sepsis, very good. Sepsis is sort of falls under the category of relative hypovolemia because in sepsis you get profound vasodilation, and you also can get some capillary permeability with sepsis as well. So the fluid's there, the fluid's in their body. It just may not necessarily be in their vessels. So sepsis is perfect, and that is one of the examples of relative hypovolemia. So what I really want to drive home about a good reason for relative hypovolemia would be anything that sort of causes profound vasodilation. Right? They haven't necessarily lost the fluid out of their body, but for some reason the vasal tone of their vessels has relaxed and increased that tank. Therefore, whatever volume blood-wise was in that tank now relatively is not near enough because the tank is a lot bigger now. Does that make sense? Okay. So sepsis is a great example of relative hypovolemia, and we'll talk about others later on this morning. And then absolute hypovolemia, I hope would make sense to you, a hemorrhage, right? Or in that example we talked about of a burn, the loss of fluid through the burn, right? The weeping, sort of evaporative loss from a burn. Okay, either way, we're going to spend the rest of the morning talking about some of these specific reasons, but what I want to drive home about this slide is that either way, no matter if it's relative or if it's an absolute loss of volume. Either way, wouldn't you agree that you have decreased circulating volume? It doesn't matter the reason why. You just overall, you have a decreased circulating volume because either one of these reasons that we gave. Yes? So with shock, it may all start different. Maybe someone went into shock because they have a gunshot wound to their abdomen. Maybe someone went into shock because they're septic. Maybe someone went into shock because they have profound burns over 45% of their body. But it doesn't matter. Either way, all the pathophysiology to a certain point sort of converges and comes together, and the pathophysiology from there forward is the same. You have a decreased circulating volume, which obviously means that you've got a decreased venous return, meaning you've got decreased blood in the system getting back up to the heart. Therefore, you have a decreased sort of stroke volume and a decreased cardiac output. The heart can't pump fluid that's not coming back to it, right? The heart can only pump what's there. So you have a decreased stroke volume, a decreased cardiac output, and then as soon as you have a decreased cardiac output and you've got a lack of blood getting pumped by that heart, you're going to see a decreased cellular oxygen supply, right? If the heart is not pumping blood to the tissues, they're not getting the oxygen. Therein lies the rub, right? Therein lies the tissue issue. You've got a lack of cardiac output, you've got a lack of blood flow and oxygen getting to the tissue, and all of a sudden, you've got decreased tissue perfusion. Does it make sense to you how no matter what the cause may be, all the causes sort of converge into the same pathophysiology, and then the pathway is sort of the same? Does that make sense? Okay. So again, after a certain point, the pathway of dysfunction is all the same, no matter what the reason initially was for the decreased circulating volume. Okay. All right, so the different reasons for that decreased circulating volume. They're sort of under three categories. Cardiogenic, meaning there's something wrong with the pump itself. There's something wrong with the heart that makes it have a decreased cardiac output. Hypovolemic, again, there's just a lack of volume. They're hypovolemic. There's a lack of volume present to get pumped around to the tissues. And then third, distributive, which is sort of that true sort of example of those relative reasons for hypovolemia. So septic, as we just mentioned already. Anaphylactic shock would also be under this distributive category, and neurogenic shock. And we're going to talk about all three of those. But really, it's kind of pretty self-explanatory in that distributive shock is not that they've got a lack of volume. It's that there's something wrong with the way that the blood's getting distributed throughout the body. So they're obviously, i.e., distributive shock. Okay, let's talk about each one of these more specifically. Cardiogenic. Reasons for cardiogenic shock. An MI. Left-sided heart failure. Dysrhythmias. Cardiac tamponade. Now, of these four things that I've just listed here, what is the common denominator? What ultimately pathophysiologically would occur because of any one of these four causes? What do you think? Right. You've got a decreased cardiac output for one reason or another. Okay? So all of these lead to, or should I say, are illustrated by a bad pump or decreased contractility of those ventricles, i.e., a bad pump, right? So really, cardiogenic shock is defined as decreased cardiac output, and it's evidenced as evidenced by tissue hypoxia, right? Now, interestingly, it's evidenced by tissue hypoxia, lack of oxygen getting to the tissues, in the presence of adequate intravascular volume, right? Just because someone has an MI doesn't mean that they're hypovolemic, right? Just because someone has left-sided heart failure doesn't mean that they're hypovolemic. It doesn't mean that they've got a decreased volume on board. What does it mean? It means that the heart just simply cannot pump the volume that's there. So it's tissue hypoxia in the presence of normal, adequate volume. Does that make sense? All right. So, clinical manifestations of cardiogenic shock. Impaired mentation, shortness of breath or increased respiratory rate, venous and pulmonary edema. Again, all of these things are basically just clinical manifestations of a lack of cardiac output, right? Dusky skin color, so sort of that bluish, dusky tint to their skin. Oftentimes when you touch someone in shock, their skin feels very cool and clammy. Why would that be? Right. I mean, you're poor perfusion to the periphery, poor perfusion to the skin. Again, you will see that hypotension and associated tachycardia. Now, in parentheses, I put behind tachycardia for a while. In early signs or early stages of cardiogenic shock, you're going to see that, or in shock in general, you're going to see hypotension with that compensatory mechanism of tachycardia for a while. Eventually, they're going to get so sick, or the heart is going to get sort of overtaxed that it's going to kind of burn out, right? And then they're not going to be able to compensate, and then you may see bradycardia. But initially, you're going to see tachycardia because the body's trying to compensate as long as it can. Eventually, it's going to kind of poop out. The heart will eventually poop out if you haven't, fixed the reasons for the cardiogenic shock. You'll also see oliguria. Now, what do I mean by oliguria? Decreased urine output, right? What should we see? What's sort of normal urine output? Do you know, like in an hour, how many cc's of urine should be made? 30. Good, right. So this is certainly going to be seeing people with less than 30 cc's of urine output in an hour. And why would that be? Mm-hmm. Decreased GFR, so decreased glomerular filtration rate. And why would there be a decreased glomerular filtration rate? Right, decrease in blood pressure, decrease in blood flow, getting to the kidneys. Kidneys can't filter blood that's not getting there, right? So you're going to see a decreased filtration rate and therefore decreased urine output. You're not going to be making as much urine because you're not having enough blood to make the urine from, right? Good. Ileus, so decreased bowel sounds, decreased sort of peristaltic action of the bowels because of, again, decreased energy getting there, so they can't do peristaltic activity without ATP, right? And then, as I mentioned earlier, an increased serum lactate. You can actually draw blood, a blood level of lactate, and can see that increase in someone who's not getting enough oxygen to their tissues. Okay, so those are the clinical manifestations of cardiogenic shock. I hope that should make sense to you, right? Basically, all of them are signs and symptoms of decreased cardiac output, decreased blood, decreased oxygen getting to the tissues. How do we fix it? Well, I will honestly tell you, cardiogenic shock is very often unresponsive to treatment, to some of these treatment options that were given here on the screen. So why would that be? So, okay, first of all, treatment here would be very, very careful fluid management. So why would you want to be really, really conservative on the amount of IV fluid you're giving to these patients? Mm-hmm. Right. So you give them more fluid, you're going to overwhelm that heart even more, right? You're going to put them in sort of fulminant cardiac heart failure, right? Because they already can't handle the fluid that's on board, and now you're giving them more. So usually IV fluid management is not the treatment for these patients because the heart is already overwhelmed by the amount of fluid in the body. It's not going to do well with more IV fluid. So very careful fluid management. Oftentimes you can give pressors. So pressors are those IV medications that actually increase the basal tone. Again, that would probably just be to sort of compensate for this lack of blood pressure, right? It's not really fixing the pumping ability of the heart. It's just fixing that hypotension by increasing that basal tone. Positive inotropes, again, remember those are those agents that help increase contractility of the heart. There are some things that they can actually do to actually help the left ventricle pump, called ventricular assist devices. These are, we're not going to get into it today, but they're actually sort of invasive, like pumps they actually put around the left heart to help it contract. Early revascularization, so in the case of like an MI, this is why we're so concerned about getting these patients to the cath lab to open up that oxygen, open up those vessels getting to the heart. That's why in the sim on Thursday we talked about how oftentimes there is a goal of getting the patients to the cath lab within 90 minutes of arriving to the emergency room, because again, muscle, time is muscle. You got to open up that vessel, getting back to that myocardium, or else the heart's going to poop out and you're going to be in cardiogenic shock. Obviously, these are people who we do not want to have a lot of physical stimulation. So these are not people that we want up running around the room and walking around. They don't have enough cardiac output to sustain that. They will not do well with any sort of activity. So rest, minimize anxiety, bed rest often for these cardiogenic shock patients. They do not have the cardiac output to sustain activity. They just don't. They will not do well. Their heart cannot keep up with that. So, yes, these are the treatment options, but I will honestly tell you, oftentimes they are very unresponsive to these treatments. There's a very high mortality rate of cardiogenic shock, as high as sometimes 70%. Why? Why would they not necessarily be all that responsive to these treatment options here? The pump is bad, right. If the heart is not working, the heart is not working, right? We can try to do these things, but if, let's say in the case of an MI, you've got a lack of oxygen and a lack of blood flow to that left ventricle that now has created an anoxic, sort of necrotic injury to the left ventricle, there's no getting that back. You can throw the kitchen sink at them. If the left ventricle is dead, the left ventricle is dead, right? And that is why cardiogenic shock can be very, very, very tricky to treat with a very high mortality rate. Very good. Okay. So we're being very, very careful with overloading that bad pump. So we're being very careful with IV fluids in these patients. And we're trying everything we can think of, anything that we can do to improve pump effectiveness. Because that is the true reason for cardiogenic shock, is that you have a lack of pump effectiveness. Okay? Any questions about cardiogenic shock? Okay. So that was the first category, right? Now the second category of shock is true sort of hypovolemic shock. So causes of hypovolemic shock. Loss of whole blood, like a hemorrhage, right? Like a trauma patient. Loss of plasma, like in the case that was given already this morning of burns. Or loss of interstitial fluid, so through really profound diaphoresis, so sweating. There's a dysfunction, sort of an endocrine dysfunction called diabetes insipidus. It's not diabetes mellitus, not like the diabetes that you think of, that causes profound fluid loss through urination and through diaphoresis. We'll talk about that next semester when we talk about endocrine problems. Or really profound emesis or diarrhea. Someone can become very hypovolemic and very dehydrated from prolonged emesis and diarrhea. So any of these reasons, no matter if it's whole blood, if it's plasma, or if it's interstitial fluid, any reason that causes a loss of these fluids can cause hypovolemic shock. So again, clinical manifestations of hypovolemic shock. Impaired mentation. Poor skin turgor. Why would you see poor skin turgor in someone with shock? Specifically hypovolemic shock, huh? They're dehydrated, right. Right, you can think of people with hypovolemic shock as pretty profoundly dehydrated for one reason or the other. They might be thirsty because of that dehydration. You will also see oliguria in these patients. You will also see hypotension and tachycardia in these patients. You will see a thready pulse. So, do anyone know what thready pulse means, or what it sort of feels like if you're doing an assessment on someone and you feel their pulse? Say that again. It's not strong, and oftentimes if you really press, when you're trying to check the pulse, and you press, you may feel it, and then if you press hard, you sort of obliterate it, like you can't feel it anymore once you press kind of firmly on it. That's a thready pulse. And again, it has to do with just the lack of circulating volume. Good. And low preload. Why would there be a low preload in these patients? Remember what preload is. It's the volume of blood getting to that ventricle, right? Getting into that heart to be ready to get pumped out. So why would you see a low preload? There's no load, right? There's no volume in the system. So you're not going to see a good adequate amount of volume getting back to that left ventricle to get pumped out because there is no volume. It's on the street, or it's, being oozing, coming out of the burns, whatever. Good. So do the clinical manifestations of hypovolemic shock look similar or look familiar to the clinical manifestations of cardiogenic shock? Yeah. And again, the pathophysiology is the same after that initial reason for why the shock is occurring. So yes, this is different in that there is a decreased volume in hypovolemic shock as opposed to cardiogenic shock. The volume was fine, it was just the pump. But either way, again, once the initial reason for shock has sort of been initiated, the pathophysiology is the same. You've got a lack of tissue, or tissue perfusion. You've got a lack of oxygen and blood getting to those tissues. Does that make sense? So how do we treat hypovolemic shock? Well, luckily, it's a lot easier to treat than cardiogenic shock. These people, you can give rapid IV replacement, right? These people, their heart's fine. They just don't have enough volume. So rapid IV fluid replacement, key with hypovolemic shock. IV fluid replacement of whatever they're missing, right? So if we know it's because of a true hemorrhage, because of a motor vehicle accident or something like that, we replace whole blood with whole blood, right? We would give these people, blood replacement, blood transfusions. If someone is hypovolemic because of profound diaphoresis, because of profound sweating, we would just replace it with IV fluids, crystalloids. So you see that here on the screen. Crystalloids are often referred to, or I should say IV fluids are often referred to as crystalloids. So like normal saline, lactated ringers, those are termed crystalloids. Colloids are like your blood products. So, obviously you're replacing what's missing. If someone is, again, profoundly diaphoretic, and that's why they're low on volume, you're not giving them blood transfusions. You're giving them what they're missing. You're giving them that fluid, that crystalloid fluid, so lactated rigors or saline. Vice versa. If you've got a trauma patient who's hypovolemic because of massive hemorrhage, you could give them IV fluid just to sort of increase their volume and increase their blood pressure, but what they really need is more blood, right? So these are the people that you're giving blood transfusions to. And we're not going to necessarily get into administration of antidiuretic hormone. We'll talk about that when we talk about endocrine next semester. So you can just kind of know it's there, and that's all. What I really want you to focus on is that rapid IV fluid replacement of whatever type of fluid is missing. Okay? Replace what's missing. Any questions about hypovolemic shock? Again, the initial reason for why someone may be going into shock or why they might have a decreased tissue perfusion may be different, but ultimately the clinical manifestations start to look the same. The pathophysiology is the same to a certain point. Lack of oxygen to the tissue. Okay. Now, last category, if you will, of neurogenic of shock, and that is now distributive shock, right? So now the heart's fine, so it's not a cardiogenic problem. There's no pump problem. The volume's fine. They're not hypovolemic per se in terms of like true volume of fluid in their body. Now the problem for why there's lack of tissue perfusion and lack of oxygen getting to the tissue is because of the way that the fluid in the body is being distributed. So there's problems with the distribution of the volume. And the first reason for distributive shock, one reason is called neurogenic shock. So let's talk about them. So the first one here is neurogenic shock. Sometimes it's also, you could also hear it referred to as vasogenic shock. And let's talk a little bit about why that occurs, the patho of neurogenic shock. So the cause is most commonly due to spinal cord injury. So when someone has a spinal cord injury, so there's been a lesion, there's been an injury, there's been some sort of ding, some sort of damage to that spinal cord. And again, we'll talk about neuro a lot next semester, but I'm going to give you sort of the quick and dirty here. With someone who has a spinal cord injury and their spinal cord has been injured at some level, whatever level it is, either high or low or wherever, what happens is if that cord is truly either transected or truly damaged, they automatically, as soon as that injury occurs to their spinal cord, they have an automatic decrease, or I should say complete lack of sympathetic stimulation below that lesion. So if the spinal cord lesion occurred here, they automatically, as soon as that injury happens, have no sympathetic innervation below that level of the lesion. Okay? So neurogenic shock occurs because of parasympathetic overstimulation and sympathetic understimulation. So think back to our discussion of sympathetic nervous system stimulation and what that does to the body. What would that do to the vessel tone if you've got no sympathetic stimulation? What's going to happen to the tone of the arteries as soon as you've got no sympathetic stimulation to that artery? Profound vasodilation. So sympathetic stimulation is what keeps our vessels toned, what keeps them nice and toned and allows for proper circulation of the fluid moving through them. When you get a complete lack of sympathetic stimulation, your arteries go from here to here in a second. What do you think that does to blood pressure? Boom! In the toilet. Right, very good. So, what does that mean in terms of the fluid getting distributed to the tissue? You don't, right? The blood cannot get circulated through those really relaxed, really sort of blown out arteries. They just sort of sit there and pool. There's not enough tone in that artery to sort of get that blood pumping to the tissues, to the organs. So, clinical manifestations of neurogenic shock are the same as all the other shocks we've already talked about. There's lack of volume, there's lack of tissue perfusion, there's lack of oxygen getting to the tissues. Plus, there's a couple special ones now with neurogenic shock. Loss of vascular tone, like we just talked about. And one really, really big difference with neurogenic shock and all the other types of shocks that we've talked about today is that You see hypotension, just like you do in all the other shocks, but you see bradycardia. Remember with the other shocks, we talked about how initially you'll see hypotension with sort of a compensatory tachycardia to try to help with that circulation of fluid. Why with neurogenic shock do you see hypotension with bradycardia? There's no sympathetic stimulation, right? So you're going to see, and it's all this overstimulation of parasympathetic stimulation, so you're going to see pretty profound bradycardia. There is no sympathetic innervation there to try to help compensate and get that that heart rate up to sort of compensate for that hypotension. So you see hypotension and you see bradycardia. That's a big, major difference with neurogenic as compared to any other shock that you're going to see. So treatment of neurogenic shock. Careful use of IV fluids, and again, pressors, those IV medications that actually help constrict and sort of recreate that basal tone until the blood pressure stabilizes. This oftentimes for these patients with spinal cord injuries, this is temporary. This complete sort of blown out vessel tone. Eventually the body kind of starts to compensate and you kind of get a little bit more tone back. It still is never quite the same, but it's not as profound as what occurs right at the time of injury. So you'll try to keep their blood pressure up with IV fluids and pressors until the blood pressure restabilizes. And one of the medications they use to sort of reestablish that sympathetic tone is neosynephrine, right? It's sort of a sympathomimetic substance, and it can actually kind of help with that, increasing that sympathetic tone again. Okay, so again, in this case of neurogenic shock, the blood volume has not changed. You've not lost volume. You've not lost blood. You simply have dramatically changed the amount of blood getting able to sort of move through those vessels and get back up to the blood or get back up to the heart for the heart to actually pump that blood back out and have an adequate cardiac output. So decreased cardiac output due to lack of venous return, because all of the blood is just sitting and pooling down in the periphery, right? Down in the peripheral, in the extremities, because there's no basal tone to pull that blood back up to the heart. So again, you see a decreased cardiac output because you have decreased venous return getting back up to the heart, because it's all pooling in those overblown, overdilated vessels. Does that make sense? So again, the reason for this shock, the reason for this lack of tissue perfusion, lack of blood getting to the tissues, is because of a distributive problem. The body can't distribute the fluid appropriately because of this loss of basal tone. Questions about that? Okay. Another example of distributive shock, so another problem with a distribution problem is anaphylactic shock, okay? So we know that anaphylactic shock, again, we've heard of all of, we know about anaphylaxis and about these acute allergic reactions, but why would an anaphylactic sort of allergic reaction cause lack of tissue perfusion? What do you think? What do you know about what occurs in anaphylaxis? Why would anaphylaxis cause decreased tissue perfusion? Lack of blood flow, lack of oxygen getting to the tissues. What do you know? What do you think? There's a little bit on the screen here. You can cheat. Okay, well, it blocks off the airway, so there's lack of oxygen getting in because there can be swelling in the airway itself, so you've got an actual airway maintenance problem. That's true. But what about the actual circulation? What about the actual flow of blood? Why would the flow of blood be changed with anaphylaxis? Yeah. Ding, 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 ding. Yes. So what's one of the big mediators that gets released in anaphylaxis? Histamine. Thank you. And what does histamine do? It vasodilates, and what else does it do? Causes vascular permeability. Very good. So now we've got vasodilation because of histamine, and we've got capillary permeability. So fluids running out of the vessels, and the vessels are getting dilated. So can you imagine why that might cause a distribution problem of blood getting to the tissues? Please say yes. Okay, good. So it begins, obviously, anaphylaxis is going to begin with this exposure to some sort of sensitized allergen that this person has. The allergen binds to that immune globulin E that we talked about with immunity, causes degranulation of the mast cells, and what's inside those little sacks of goodies? Mast cells? Histamine. Right, and chemotaxic factors. Good. So mast cells release that histamine, causes the profound vasodilation, causes that profound vascular permeability, and lo and behold, you've got a distribution problem, right? You've got lack of blood in the vessels to be distributed. And there you go. Then from there, pathophysiology is the same. Decreased venous return, getting back up to the heart, decreased cardiac output because of that, decreased blood flow, decreased oxygen getting to the tissues. Does that make sense? Please say yes. Thank you. Okay, so clinical manifestations, same as all the other shocks, right? Hypotension, tachycardia, lack of mentation because of the lack of blood flow to the head. Plus, you get all the goodies of an allergic reaction, right? So you get the shortness of breath, the wheezing, you get the urticaria, which are those like hives. You get the swollen lips and the swollen tongue and the swollen airway, like you mentioned. And again, why? Why do you see that profound lip swelling and tongue swelling and throat swelling? Because of the capillary permeability, because of the edema. All the fluid is leaking out of their vessels into their tissues and causing edema, including edematous lips and edematous tongue, right? And you can sometimes get abdominal cramping too if it's an allergic reaction to something that they ate, so shellfish or peanuts or something like that. So, anaphylactic shock looks the same as the other shocks. You got your hypotension, you got your tachycardia, you got your lack of tissue perfusion to all the tissues in the body, plus you've got sort of the symptoms of an allergic reaction sort of superimposed on top of shock clinical manifestation. So how do we treat it? We'll get rid of the trigger, right? Get rid of the peanuts, get rid of the shellfish, get rid of the beast, like whatever it is, get rid of it. And then there's a lot of medications that you give. So obviously IV fluids can help get that volume back up. If they're pretty profoundly vasodilated, IV fluids will help get that volume back up and increase their blood pressure. One of the major things, if I could put stars, 50 different stars on the sub-Q or the IV epi, I would. Because why is this so important in anaphylactic shock? What does epinephrine do to sort of help turn around anaphylactic shock? Say it again. Say loud. It causes vasoconstriction, which is exactly what we need right now when all their vessels are blown out. So it causes vasoconstriction, so it helps suck that basal tone back in. And it also reverses airway constriction as well. Okay? So that's why we love epi in an anaphylactic shock situation, because it increases basal tone, it causes vasoconstriction, and it reverses airway constriction. And then there's some other goodies that you give at the same time as well. You give some sort of antihistamine, again, to counteract the effects of the histamine. And you also give corticosteroids. One we give in the ER all the time for anaphylaxis is Solumedrol. Again, it's an anti-inflammatory, so it helps with some of that inflammatory swelling, inflammatory processes that are going on. You also may give some inhaled bronchodilators to help with the airway and the breathing issues of an anaphylactic shock, or anaphylaxis, I should say. We also will quite readily put these people, intubate them and put them on mechanical ventilation until all the swelling goes down. Even if they come in, pretty profoundly in anaphylaxis, swollen shut eyes, their mouth is swollen, their tongue is protruding because it's so big it can't fit in their mouth kind of thing. Even if they're talking and even if they're still moving air, we will quite oftentimes just go ahead and intubate these patients and put them on mechanical ventilation until all of the swelling goes away. Why? Why would we do that so readily and so quickly without missing a lot of time? Exactly. These people can lose their airway in a second. And once you've got complete constriction because of all that edema in their airway, it is pretty darn impossible to get a tube down. We'd rather do it preemptively and do it while they're still talking and moving air than to lose that airway completely because of the edema. Again, because of the effects of that histamine causing such profound capillary permeability. So we will not hesitate to mechanically ventilate someone who's coming in with anaphylaxis because of that. In a second, you can lose their airway, and then it's really hard to get a tube down. Okay. So again, very sudden death can occur within minutes unless you do all of these sort of emergent treatments for anaphylaxis. And again, with anaphylaxis, it's kind of complicated because you get all this sort of airway problems that you would sort of think of with an anaphylactic reaction, an allergic reaction. Plus, you get all the sort of cardiovascular, distributive, issues with their cardiac output. So it's a double whammy with these patients. That's why they're so sick and why they can die, pretty quickly. Okay. Any questions about anaphylaxis? It's also a distributive problem. It's the way that the fluid is getting distributed in their body is what the problem is with the tissue perfusion. Yeah. Yeah. Yes. 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 To a certain degree. Now, some people are going to come in with an allergic reaction. They're never going to go into true, full-blown anaphylaxis. But if you're seeing all these kinds of things that we're talking about, they're short of breath, that you hear that audible stridor, that, my gosh, it's scary when you hear someone out in triage like that. You're like, okay, here we go. You're going and getting all this stuff out of the Pyxis right now. So not everyone who comes into the ER is in true anaphylaxis or in true anaphylactic shock. You can certainly have someone have an allergic reaction without all of this occurring. But once you start to see these signs and symptoms, you have to act pretty quickly. Does that answer your question? Okay. All right. And the last type of distributive shock is septic shock. And again, we're not going to spend, this is an extremely complicated pathophysiologic pathway for why sepsis causes shock. But we'll kind of give you, again, I'll kind of give you the quick and dirty for today. So causes of septic shock begin with an infection, right, somewhere in the body that progresses to bacteremia, meaning progresses to an actual infection, actual bacterial growth in the blood, right? And then once there's bacteria in the blood, that blood circulates all over the body, right? And that infection can go everywhere. That infection can spread everywhere. This is one of the most common causes of death in critical care settings. So in the ICUs, you're going to see a lot of septic shock. Again, the overall mortality can be pretty high with septic shock, anywhere from about 30 to 60% mortality rates of people with septic shock in the ICUs. So as I mentioned, it begins with an infection. Now, a profound, widespread bodily infection. So what did we talk about in terms of effects of inflammation? And this is definitely widespread inflammation in the body. What do you see hemodynamically in a profound inflammatory response in the body? What do you see? I can tell you, it's pretty darn similar to everything else we talked about today. Hypotension, vasodilation, tachycardia, capillary permeability, right? All those signs and symptoms of an inflammatory response are going to occur in this widespread bodily infection. Septic. They're septic. They have sepsis. So, you're going to see all the same signs and symptoms of someone in septic shock as you have with the other patients, because, with the other shock scenarios we talked about today, because you're seeing the same stuff. Yes, the reason for their vasodilation is different than, say, someone with anaphylaxis or someone with a neurogenic, vasodilation. But it doesn't matter what the reason for their vasodilation is. Once they're vasodilated, the pathophysiology looks the same, right? Lack of venous return up to the heart, lack of cardiac output, lack of blood and oxygen getting to the tissues. I hope this is you're starting to see the pattern here. So again, infection triggers systemic inflammation, which leads to that widespread vasodilation. So you'll see all those signs and symptoms that we already talked about. Now, late stages of sepsis, you can actually see decreased myocardial contractility, which also then obviously compounds the issue of this decreased cardiac output. But the most common sources or sort of reasons for why these patients may become septic in the first place is because of some sort of lung infection. Oftentimes it's very, very common to see people coming in with like a urinary tract infection, either just because or because they have an indwelling catheter. That's like, in the ER, I feel like I see it all the time. Patients come in what they call uroseptic, like from a nursing home or something like that have had long-term, urinary catheter in place, that there's an infection because of that catheter, and they're sick. I mean, blood pressure's in the basement, and it turns out decreased cardiac output, all of that. And it turns out that the infection stemmed from that indwelling urinary catheter. You can also see it from patients' wounds. So again, you see it a lot in like a trauma ICU because of profound wounds from some sort of trauma that get infected. Or indwelling vascular catheters. So it's quite common to see the culprit of sepsis come from like a central line, right? Because of the direct access from the outside world right into their vein. So these are some common sources of why someone might actually start down the pathway of septic shock. It can be caused by any class of microorganism, but I will honestly tell you, especially in our hospitals and the ICUs, that oftentimes it's like a gram-negative bacteria, usually. But again, the patho is that it causes massive inflammatory response, which causes massive vasodilation. And again, then the patho is the same. All right. Any questions about shock? Again, the reasons can be different, but once the reasons kind of converge into one pathway, then the pathway is sort of all the same no matter what the reason may be. All right? Any questions? All right. Because we had the quiz, and then because we're going to stop a little bit early, I apologize. I am not going to necessarily give us a formal break because we were only having about an hour or so of true lecture time anyway today. So if you need to get up and run to the bathroom or, get rid of some of your coffee or whatever, please do, but I'm not going to stop today just because we're really only talking for an hour anyway. So to take a true formal break, we'd be losing some time here today. Okay? Don't all leave now. Then I will have to take a break. Okay. So we've got about 35 minutes or so to cover some of the main stuff of this cardiovascular function in children. All right. So, with alterations of cardiovascular function in children, the importance of understanding that flow of blood through the heart that we talked about on this very first day of our, the very first day of our cardiac unit is super, super important. Because most of the alterations of cardiovascular function in children have to do with some sort of congenital heart defect. So there's something structurally going on with the heart that impedes or redirects the flow of the blood through the heart, which causes some sort of unnatural flows or unnatural ways that blood gets pumped through the heart. And so understanding that flow and the correct flow of blood through the heart will then obviously lead to a better understanding of these alterations of flow or the alterations in the direction of flow in the child's heart with some sort of congenital defect. So, objectives for you. All right, so congenital heart defects. Major cause of death in the first year of life in children other than, just true prematurity. So it's another major cause of death or morbidity and mortality. Reasons for congenital heart defects, there could be some sort of prenatal and environmental kind of factors. And when I mean environmental, I mean sort of environmental of the mom. So, while the baby is in utero. And then there's some genetic risk factors as well. So environmental / prenatal maternal reasons could be some viral infections that the mother could have acquired while pregnant, an increased age of the mom. Sometimes having type 1 diabetes can actually increase the risk, alcoholism, and then some other things you see there as well. Genetic factors could oftentimes, interestingly, some chromosomal aberrations like Down syndrome are often linked to specific types of congenital heart defects, and we'll talk about a couple of those, or one specifically, in just a minute. So again, can be some factors, can be some reasons for why congenital heart defects occur, and sometimes there's really no reason or no link we can sort of link back to that defect at all. But here are some sort of common risk factors. I just want to sort of mention those to you. And again, congenital heart defects can really range from very mild and very fixable to life-threatening at a very early stage in life. So kind of keep that in mind as we go through some of these defects this morning. Okay, so congenital heart defects can be classified on a couple of different bases. One, they can be classified by whether or not they cause the blood flow to the lungs to increase. And then there are types of heart defects that cause the blood flow to the lungs to decrease. And then there are some that actually don't really affect the blood flow to the heart at all. So that's one way we look at and classify these defects. Another one is, does this particular heart defect cause cyanosis? So obviously 1 and 2 are kind of linked together, right? If you've got an increase in blood flow to the lungs, you probably will not see cyanosis in this child. If you've got a lack of blood flow to the lungs, you probably will see cyanosis, a blue discoloration of that baby or of that child, because you're not getting blood flow to the lungs to become oxygenated, right? And then another way that we can classify heart defects is there an obstruction of blood flow somewhere in the heart? So we'll talk about those. But again, cyanosis can be caused by defects that either restrict blood flow into that pulmonary circulation. Maybe cyanosis is caused by an overload of the pulmonary circulation, so they kind of have almost like that pulmonary edema sort of signs and symptoms that we've talked about already. Or you can get unoxygenated blood because of, we'll talk about this in a second, but you can get unoxygenated blood from the right side of the heart to shunt into the left side of the heart because of a defect in the septal wall and get pumped out to the body before it gets to the lungs. So that could also obviously cause cyanosis in a baby as well. So let's talk about some of these. Okay, so the first sort of category of defects we're going to talk about this morning are obstructive defects. And the first one of the obstructive defects is something called coarctation of the aorta. Coarctation of the aorta usually occurs because of a narrowing of the lumen of the aorta. So an actual narrowing of the sort of diameter of the aorta that impedes blood flow, right? So obviously if you've got a stricture in the aorta, it's going to be really hard to get that blood that's getting pumped out of the left ventricle. It's going to be really hard to get that blood pumped to the whole body when you've got a blockage basically in that aorta. Oftentimes you'll see this coarctation or sort of this narrowing of the aorta right around an area of the aorta where the insertion of the ductus arteriosus is in the fetus. Okay, now go back to your pediatric physiology. Anyone know what the ductus arteriosus is or what it's for in the fetus? Mm-hmm. Right, exactly. So in utero, the fetus's lungs are filled with fluid, right? And they're not breathing oxygen, obviously. They're getting their oxygen and their nutrients from the mother. So blood does not need to go to the lungs in the fetus. So instead of having the blood go to this fluid-filled lungs that are non-functional in utero, there is a duct where blood that goes up into the pulmonary artery, instead of going to the lungs, goes straight into the aorta and to the rest of the body to be circulated that way. So it bypasses the lungs. Now, as soon as the baby is born and the umbilical cord is cut and they take their first breath, that ductus arteriosus starts to close because, yes, now we need blood to go to their lungs, right? So oftentimes, right around that site of where that duct is, that ductus arteriosus is, in a coarctation of the aorta right around that site of the DA, the ductus arteriosus, is restricted. It gets clamped or smaller in coarctation of the aorta. So clinical manifestations of what you may see if a child has narrowing of the aorta is obviously if it's pretty severe, you're going to see decreased cardiac output because you just can't pump blood to the body because there's a obstruction in the aorta. So you'll see poor tissue perfusion, you'll see hypotension. Sometimes you'll see weak or absent femoral pulses. So you'll actually see decreased pulses to the lower part of the body in this baby. Why? You're not getting blood to the lower part of the body, right? It's getting blocked in that coarctation area of the aorta. And interestingly, so that could be on more of severe coarctation. If more mild, interestingly, you may not see manifestations early on in a baby. Sometimes what you'll see later on in childhood or at an older age in the pediatric population is you'll see hypertension in the upper extremities, so like in the arms and kind of in the neck and that sort of thing. Why would that be? Why would you see hypertension in the lower extremities and decreased blood pressure increased hypertension in the upper extremities and low blood pressure or weak pulses in the lower extremities? Yeah, you got more blood flow to the upper part of the body and not enough to the bottom part of the body because of that restriction and that coarctation in the aorta. You also, because of that lack of blood flow to the legs and to the muscles in the legs, you may see leg pain or leg cramping, specifically with increased exercise or increased physical activity in older children. Again, because of that lack of blood flow, because of that coarctation. Oftentimes, if the newborn is symptomatic as soon as they are born, they'll give something called IV prostaglandin E1, and that actually keeps that ductus arteriosus open. Again, normally it should close pretty soon after birth, but if someone has a coarctation of the aorta, we actually want to keep that ductus arteriosus open to allow for blood circulating. So they'll keep that open until they can get that baby to the OR and surgically resect and sort of open up that area of the aorta, to allow for proper blood flow through that obstruction. And obviously the location and the severity of the coarctation determines whether an infant becomes symptomatic as soon as they're born, and as soon as that DA, that ductus arteriosus starts to close. If it's a pretty bad coarctation of the aorta, once that ductus arteriosus starts to naturally close, they're going to get more and more symptomatic because you've got less and less blood being able to be sort of shunted and redirected around that coarctation. So here's a good picture of it. See how this aorta here is just sort of pinched? It's not open. This area right here, you sort of have this pinching aspect of the aorta. Obviously not enough blood flow is going to get through there because of this pinching of the lumen. Here's a really good sort of real cross-section of it. Again, here's the branches that branch off of the aorta. And look how the lumen should be up here, right? And look how this aorta is so restricted and pinched right here. And just FYI, this little asterisk right here is the ductal arterial ligament that sort of used to be the ductus arteriosus. It gets sort of filled in after birth, and it just becomes sort of this ligament there. But this used to be open, and that used to be the ductus arteriosus. Okay? Let me ask you this. Would coarctation of the aorta and this increased restriction of blood flowing out of the left ventricle through the aorta to the body, would this cause an increase or a decrease in left ventricular afterload? An increase in afterload, right? Because remember, the true definition of afterload is the pressure in which the left ventricle has to pump against to get the blood out. This is going to cause a lot of pressure. This is going to cause a lot of backup of blood and a lot of pressure. Good. Good, good. All right. Another reason for an obstructive defect in the pediatric heart is aortic stenosis. And again, hopefully the term itself should be pretty intuitive for you. It's basically a narrowing just of that aortic artery outflow tract. So right where the aorta sort of sort of comes together with the left ventricle, there's some sort of malformation there. Either a malformation of the valve itself, so there's sort of a malformation or a fusion of some of those cusps of the aortic valve, or there can actually be sort of a stricture to the aorta itself, sort of right below the valve. So a stricture caused by sort of this fibrous ring right below the aortic valve that again causes a stricture of blood flow from getting from the left ventricle out into the aorta. So aortic stenosis. Again, would a stricture right at that area from the left ventricle out into the aorta, what would that do to afterload? Say it again. It would increase the afterload. Again, because it's a roadblock, right? That stricture around the aortic valve is causing a roadblock for blood getting from the left ventricle out into the aorta. So it's going to increase afterload. It's going to increase that pressure that the left ventricle has to pump against, right? So it causes increased workload on that left ventricle. And what does an increased workload on that left ventricle over time chronically cause? Left ventricular hypertrophy. You're going to see that muscle of the left ventricle get bigger and get hypertrophied because of that pressure that it's constantly trying to push against with this hard, stenosed, restricted aortic valve. Again, clinical manifestations In the baby, you could see significant faint pulses in the systemic pulses being very bad because of a lack of blood flow getting out of that left ventricle through that aortic stenosis into the body. You'll see hypotension, again, because of lack of blood flow getting through that stenosed area. You also can see in the infant really poor feeding. Why do you think babies that have aortic stenosis might have trouble eating? Mm-hmm. Yeah. Right. It's hard to suck, breathe, and swallow all at the same time in these babies, right? And they do not do well, either with breastfeeding or with bottle feeding. Oftentimes they'll have a lot of trouble sucking and swallowing and breathing all at the same time because of this lack of cardiac output and this lack of tissue perfusion. Good. Very good. If it's more mild, you may not see clinical manifestations until, again, the child gets older. And you'll start to see, like, your toddler or your young child kind of having complaints of, like, exercise-induced intolerance or fatigue. You'll see that with, like, strenuous activity of them running around on the playground or, at the park, that they don't have the same sort of stamina as, like, other kids their age. Again, lack of cardiac output, right? Decreased cardiac output because of that stricture in the aortic outflow. Oftentimes, too, with these valvular or just congenital defects in general in the heart, oftentimes, and I don't know that I can completely explain this to you for why, these people are more at risk for bacterial endocarditis. So a bacterial infection of that most inner lining of their heart. You'll see that time and time again with a lot of these heart defects, that they're also more at risk for an infection to that inner lining of the heart. How do they treat this? They do what they call as aortic valvotomy. Is it sort of an early palliative procedure? The aortic valvotomy is just sort of this balloon that they thread up into that valve, into that aortic valve area, and just sort of blow it open to sort of push that stricture, that stenosis, kind of open, so to allow for more blood to get from the left ventricle into the aorta. The valve is oftentimes very stiff and hard, and that's why you have that stricture of blood getting from the left ventricle out into the aorta. So the balloon kind of helps open that and allow for more blood to flow. It's palliative, though, because that's not going to probably be a long-term fix. So oftentimes they'll do the valvotomy while they're waiting to do a valve replacement. So valve replacements are usually required subsequently afterward. And here's a good picture of that. So left atrium, left ventricle. Look at how sort of closed and restricted this outflow of blood through this stenosed aortic valve is. You can imagine that the narrowing of this aortic valve causes resistance to blood flow in that left ventricle, which obviously decreases cardiac output, which causes left ventricular hypertrophy, and obviously then ultimately pulmonary congestion, right? Because then you start to get that backflow, that backup along that flow of blood. Very good. Okay. Pulmonic stenosis is basically the same thing. So you've got this stenosis, this stricture of now instead of on the left side of the heart with the aorta, now you've got that stenosis to the pulmonic valve on the right side of the heart. So narrowing of the pulmonary outflow tract. Again, because of an abnormal thickening of the pulmonary valve leaflets. So now you're going to see basically all the same stuff that you saw on the left side with the aortic stenosis, you're going to see now on the right side. So you're going to see right ventricular hypertrophy. You're going to see issues with getting blood flow now from the right ventricle to the lungs, etc. So clinical manifestations, again, mild cases you may not see much at all. More severe cases, you might see cyanosis because of what we call a right to left shunt through an atrial septal defect. Okay, now wait a second now. Why would there be a flow of blood from the right atrium directly to the left atrium? Why physiologically, or how physiologically would that occur? Anyone know? I hear murmurs. Would you like to try your hand at it? Anyone? Okay. So there's actually two, shall I say, shunting systems in the fetus, right? We talked about the first one, the ductus arteriosus. There's another one, Where's the other shunting process occurring in the fetus? Between the two atriums, and what's that shunt or that hole called? Anybody remember? Foramen ovale, right? It's actually a hole in the septum between the atriums, right? There's a hole in the in the septal wall between the two atriums that in the fetus allows for blood flow to go from the right side of the heart directly to the left side of the heart. Now, in someone with pulmonic stenosis, in a baby or a child with pulmonic stenosis, there's so much pressure that mounts on that right side of the heart because it can't get through that pulmonic valve up into the pulmonary artery that it basically puts so much pressure on that closing foramen ovale that it opens that foramen ovale again and allows for blood to flow from the right side of the heart to the left side of the heart. Now, in a non-fetus, right, in someone who's not in utero, what would shunting from the right side of the heart to the left side of the heart cause? Perfect. That's what I wanted you to say. There would be an increased distribution of unoxygenated blood to the system, right? Because the blood would go from the right atrium to the left atrium. I'm doing this backward, I'm sorry. From the right atrium to the left atrium to the left ventricle out to the body. Did it go to the lungs? No. So now you're pumping and you're distributing non-oxygenated blood to the system. So pulmonic stenosis is a great example of a congenital defect that causes cyanosis, right? That causes these babies or these children to look bluish because you've got non-oxygenated blood pumping to the system, pumping to the body. Yeah. You mean of that fetal shunt? Yeah. So the one in the septal wall between the atriums is the foramen ovale. And I'm sorry, these markers never work. Foramen ovale. Try another marker here. The one in the shunt between the pulmonary artery to the aorta is the ductus arteriosus. That help? Again, very similar to aortic stenosis, the treatment for pulmonic stenosis is usually balloon angioplasty as well. Go in there, blow open that restricted valve, and allow for more blood flow to flow into that pulmonary artery. Here's a picture of that. Right? Here's this pulmonic stenosis here of the valve from the, again, between the right ventricle and the pulmonary artery. Here's the example of how they thread a catheter into the heart and put a balloon right in that area and blow up that balloon in that valvular area and sort of dilate that area. Then they deflate the balloon and hopefully that area has now sort of been pushed and dilated a little bit to allow for more blood to flow through. Okay, so those are our obstructive defects. Now let's talk about defects that increase pulmonary blood flow. Okay, so the first one we're going to talk about is something called the patent ductus arteriosus. So this is caused by, very simply, a failure of that ductus arteriosus to close at birth. So again, as soon as the baby is born, as soon as they take that first breath, that ductus arteriosus will start to close. And within, I think it's like literally a day or so, it's completely closed. So within a couple of days of life, that DA is closed. But for some reason in these babies, it stays open. So it's patent. It does not close. So a patent ductus arteriosus allows blood to shunt from the aorta into the pulmonary artery. Now, wait a second. I just said that in the fetus, it's meant for blood to go from the pulmonary artery into the aorta and to skip the lungs. So why in these neonates, why in these babies that have now been born, does the blood shunt from the aorta back into the pulmonary artery? Why is that, pathophysiologically? Because the pressure in the aorta is so much higher, right, than the pressure in the pulmonary artery once we're born, that the blood just passively gets pushed from the aorta, that high pressure system, into the lower pressurized pulmonary artery. So it causes a left to right shunt. And so now does this increase or decrease the amount of blood flowing through the lungs? It increases it, right? Because not only do you have the blood coming from the right ventricle going up into the pulmonary artery and into the lungs, but now you've also got the blood from the left side of the heart getting shunted, from the aorta back into the lungs as well. So it increases blood flow to the lungs. So you usually don't see cyanosis in these patients. Why? Because you've got extra blood going to the lungs, not a decrease in blood going to the lungs. Oftentimes you'll hear, if you actually auscultate with your stethoscope over that area of sort of, where the ductus arteriosus is, you'll hear a specific kind of murmur. They call it a machinery murmur. And it has actually to do with that sort of turbulence of blood moving through that defect, right? Moving through that shunt from the aorta into the pulmonary artery. And it literally sounds like brrrr. I mean, it sounds like a machine, right? Of that high turbulent blood flow getting pushed through that hole back into the pulmonary artery. They could be asymptomatic with this, or depending on the degree, you can see pulmonary overcirculation. So you can see shortness of breath, you can see fatigue, you can see sort of pulmonary edema kind of symptoms because of this overload of fluid in the lungs. Again, you also may see poor feeding in these infants because, again, it's really hard to suck, swallow, and breathe all at the same time. So you can see issues with weight gain, or I should say lack of weight gain, in these neonates. These patients are also more at risk for pulmonary vascular disease later in life. And again, it probably has to do because of the fact that these babies have pulmonary hypertension, right? They've got a hypertensive state in their lungs because of this increase of volume in their lungs. So they can have issues with pulmonary vascular problems later on in life. And again, as I mentioned already, they also could be more at risk for bacterial endocarditis. Treatment is pretty straightforward, pretty easy. They just surgically go in and place sort of an occlusive device or a plug, literally, over that hole, over that ductus arteriosus that should have closed and didn't. You can also see with babies, a baby can't tell you I'm short of breath, right? What might you see in a baby who's short of breath or who's having trouble, with perfusion and oxygenation? What kind of things might you see in a baby? Flaring. So nasal flaring, retractions. You can see sort of around their intercostal muscles and around their little tummies. You can actually see sort of retractions going on. You can see sort of those intercostal ribs and their tummy sort of retracting unusually during breathing. And you also at times when babies are feeling short of breath, you hear sort of a grunting sound as they breathe. So it's kind of a as they're trying to move air. So again, babies aren't going to tell you they're short of breath, but if you see any of these things, it's quite worrisome. Okay? And again, here's a good picture of this patent ductus arteriosus. So blood gets pumped from the left ventricle into the aorta instead of going to the whole body. Some of the blood gets shunted back in through this hole here between the aorta and the pulmonary artery and goes back, back into the lungs. And here's a really good picture of a real picture. So here's the aorta, and here's the patent ductus arteriosus. So the blood just goes right from the aorta, right back into the right and the left pulmonary artery and right back to the lungs. Okay. Another defect that increases pulmonary blood flow is an atrial septal defect. So again, it's an abnormal communication across the intra-atrium septum where blood flows from the left atria to the right atria. Now again, it's probably due to a lack of the closure of the foramen ovale, right, between the two and that septal wall between the two atriums. So it causes blood flow, again, to flow from the left atria to the right atria. Again, why? Why is blood flowing from the left to the right instead of the right to the left through these defects? The left side is more pressurized, right? So it's just going to make sense that the blood gets pushed from the left to the right side because there's just more pressure on that left side. So again, oftentimes these patients may be asymptomatic in an early age, where there's, defects are so mild that they can go undetected until preschool. Oftentimes you will hear an audible soft murmur in that area, again because of that turbulent blood flow through that defect. And you oftentimes will see, as they get older, more pulmonary symptoms on exertion at a later age. So again, a toddler who's running around on the playground or at the park and feeling short of breath or getting winded or not able to sort of keep up with their age cohorts running around, things like that. Again, treatment pretty straightforward. Surgical placement of a patch or some sort of ligation to close that hole in that septal wall. Okay. Again, a lot of these defects are pretty self-explanatory if you understand the flow of blood through the heart, right? And that's why I said that at the beginning of the lecture. So not only can you have a defect in the atrium septal wall, but you can also have a ventricular septal defect as well. So a defect in the septal wall between the two ventricles. Again, small defects, perhaps not a lot of symptomatology or pathology. Large defects, okay, this is kind of interesting. Think about this for a second. Large defects in the septal wall between the ventricles can actually increase pulmonary blood flow from that left to right shunt and cause pulmonary hypertension. But it also can sort of overload the left heart because instead of blood moving from that left ventricle out into the aorta and out to the body, you basically just kind of have it circulating right back to the left ventricle, right? So you go from the left ventricle to the right ventricle to the lungs to the right to the left atrium to the left ventricle back through the right ventricle again. So you don't have all this blood getting pumped out to the body, and you just kind of have it keep circulating back to the left ventricle, and you can kind of overload that left side of the heart, specifically the left ventricle. That syndrome of just sort of this recirculation within the heart and not out to the body is a term called Eisenmenger syndrome, just so you're sort of aware of that. And I mentioned that there being some chromosomal abnormalities that are sometimes associated with some of these defects. This is the one, ventricular septal defect. This is the one that is extremely common in Down syndrome. Just kind of FYI. You may need to know that. Okay. The next one, a couple more minutes here. Atrioventricular canal defect. So now this is a defect that still increases pulmonary blood flow, still increases flow to the lungs. Results from non-fusion of the endocardial cushions. So anyone know what endocardial cushions are? I did not, I'll be honest with you, as a nursing student. What they basically are is in utero, so in the fetus, this is the tissue that is responsible for septal wall formation in the fetus. So there's a lack of growth, basically, of that septal wall between, now we're talking about lack of septal wall sort of dividing between all four of the chambers. So it demonstrates abnormalities in the atrial and the ventricular septal wall, and oftentimes the valves can be affected as well. So again, because there's more pressure on the left side than the right side, the flow generally does go from the left to the right. Let's take a look at a picture here. So look at this septal wall defect. It's not necessarily just between the atriums, not necessarily just between the ventricles, but look, the whole middle septal wall doesn't even go up and connect. So basically all four chambers can talk to each other. The blood can flow just between all four of the chambers. So, obviously, depending on the extent of this, you can get pretty moderate to severe heart failure due to that left to right shunting and pulmonary overcirculation. You will now start to see some cyanosis, especially when the baby is crying. Why might you start to see some cyanosis now in this particular defect? The baby might actually look sort of blue, dusky. Yeah, the blood is just sort of mixing. So some of that unoxygenated blood from the right side of the heart is getting into the left side of the heart and being pumped out to the body, right? So there is some mixing of oxygenated and non-oxygenated blood that is ultimately getting pumped out to the system. So that's very true. You also, again, may hear a murmur. The murmur is quite common in a lot of these defects because of that turbulent blood flow across and through that defect. And again, obviously, hopefully it makes sense to you that they're, again, at risk for developing pulmonary hypertension if you leave it untreated, because you're, again, probably going to overload that right side of the heart and overload the amount of fluid getting to the lungs, because blood will shunt from the left side to the right side because of the increased pressure on the left side. So you have to medically manage their congestive heart failure symptoms. And they oftentimes will do a surgical repair as the baby gets a little bit older. So 3 to 6 months usually is when they'll start to consider surgically repairing this huge septal defect. And again, you want to try to do this to prevent some of the irreversible problems that can occur later on if it's not fixed. So the defect, again, allows for simultaneous communication between all 4 chambers. You can imagine the havoc that can wreak, right? Okay. So now we're going to talk about defects that decrease pulmonary blood flow. So can you imagine now that what's the big symptomatology that you're going to see of all of these defects that decrease blood flow to the lungs? Cyanosis, right? These are the defects that will be cyanotic type of defects. The first one that we're going to talk about here is called tetralogy of Fallot. So the term tetralogy should tell you that 4 things are wrong in this syndrome. So this syndrome represents a ventricular septal wall defect. It represents pulmonary valve stenosis. We talked about those 2 things already. And you'll also see something called an overriding aorta in this problem, and a right ventricular hypertrophy. So let's take a look. It's going to be easier to actually look at this and make sense of it. Here's the 4 things that occur in this syndrome of tetralogy of Fallot. So you see the pulmonic stenosis. You have the stricture of that pulmonary valve. We've talked about that already. So obviously, hopefully, that should make sense of why you see right ventricular hypertrophy, right? Because you have this increased pressure of the right ventricles trying to pump against to get the blood out. You see this ventricular septal defect. So you see how there's a defect between the 2 ventricles. And you also see now this issue of what they call an overriding aorta. Do you see how the aorta sort of overrides both sides of the heart? It's right here in the middle, so it's getting blood. It's overriding the right side and the left side of the heart. So the aorta is receiving blood, now not just from the left side of the heart, but also receiving some blood from not just from the left side of the heart, but from the right side of the heart as well. So you have some of this unoxygenated blood getting up into the aorta and getting, pumped to the rest of the body. So hopefully that should make sense of why this is a cyanotic defect, because you're getting unoxygenated blood pumped out to the body. And that's tetralogy of Fallot. You will see acute cyanosis at birth. There's really no way around it, right? If you have all of these defects going on within the walls of the heart, you will see a blue tinge, a cyanotic look to these babies at birth. Or gradual cyanosis over the first years of life, depending how bad those defects are. You'll also see some what they call gradual clubbing. We'll talk about that in just a second. And you'll see poor growth in these babies. Again, it's really hard to suck, swallow, and eat at the same time. You'll see TET spells. TET spells are, they call them TET spells because you usually see them a lot with tetralogy of Fallot. They're usually these acute episodes of cyanosis and hypoxia, especially with crying. So when a baby cries, it increases their oxygen needs even more, and they just don't have the capability to get the oxygen, to the tissues during crying because of this, cyanotic type of defect. So oftentimes you'll see this shortness of breath occur during these crying spells, and they call them a TET spell. The thing that I want to explain next is this gradual clubbing that occurs. We'll talk about that in just a second. But the surgical repair of each one of these defects, each one of these 4 defects that occur with tetralogy of Fallot, is what needs to happen. So you have to repair all 4 of these problems to adequately fix this problem. Let me take a look at this clubbing situation, and then we'll stop there. Okay, So clubbing. Anyone seen this look on anyone's fingernails that they've taken care of in clinical or in some of your experience? So this is clubbing. Not completely understood about why this happens, but you will see this in patients that have lived a while with chronic hypoxia. So, and the reason, again, not completely understood, but the reason they think this sort of occurs is that there's an increase in vascular endothelial factors that sort of get deposited in the tips of fingernails, in the tips of the fingers here with people with chronic hypoxia. And it's a very common sort of symptom in people with disorders of chronic hypoxia. So yes, you might see it in these children with tetralogy of Fallot, but the type of patient that I've seen it a lot in is patients with cystic fibrosis. Like teenagers, people who have had it for several decades, have chronic hypoxia for several decades, you often see this clubbing going on. Okay. All right, we are going to stop there because Austin is here. So I will do a super short voiceover on these last 1, 2, 3, 4, 5 slides. Because from, let's see, the mixed defects slides, if you look at that, I'm not going to necessarily test you over the mixed defects. So it's really only just these next few slides until we get to the mixed defects that you'll be tested on. So there's really only just a couple more slides that I want to talk to you guys about. And lastly, I just want to bring your attention to the very last slide of the lecture. In order to just kind of help you sort of summarize the two kind of different categories of congenital heart defects that we've talked about today, you either have your defects that cause cyanosis, or you have your defects that don't cause cyanosis. And I've kind of just illustrated them here for you in a nice little organized chart for you. Okay? So again, I will do a quick voiceover on tricuspid atresia, transposition of the great arteries, and we will stop there. You will not be tested on mixed defects. Does that make sense? All right. Thank you very much.